Good morning, everybody. Welcome to the ART Conclave 2021, organized by Oasis Fertility. I'm Dr. Sreevani, Clinical Head and Consultant Fertility Specialist at Oasis Fertility, District Nagar, and I'm excited to present you this edition of ART Conclave after a long gap. COVID-19 has taught us a lot of lessons, but we at Oasis Fertility believed in the phrase called being resilient and did bounce back. Before we start our meeting, I would request everybody to switch off their mobiles and please occupy the front seats. While to give you an overview of the prevalence of infertility, nearly 10 to 15% of married couples in India, things like PCOS, tuberculosis, endometriosis, etc., all these things play a role in the rise of fertility issues. In India, the general notion or myth is that infertility clinics are meant only for treating women. The entire male infertility gamut is just ignored. While we at Oasis offer all services and treatments for fertility under one roof, Oasis Fertility, we are proud to share that in the last 11 years of our journey, we have built one of the most respected institutions in the field of reproductive medicines in India and have helped over 35,000 couples achieve their dreams, and we ensure that the highest level of quality is maintained here. Our lab is one of the very few labs in India that has proper quality, total quality management in place, which optimizes the results of assisted reproductive techniques. We are one of the first in AP Telangana to provide advanced services like PGS, PGD, IVM, macro-TC, vitrification and fertility preservations. Through advanced treatments like PGS, vitrification, micro-TC, the success rates have improved. We at Oasis, we treat a lot of couples with history of failed IVF and successfully offer better pregnancy rate. Well-trained, experienced team with a state-of-the-art. The objective of conducting the Assisted Reproductive Technology Conclave to train clinicians from across the city by the way of interactive session on the latest treatment trends and the next generation upcoming technologies. At the end of it, we expect the participants to get empowered with knowledge and recent updates on fertility treatment aspects so that they can start treating more of infertile couples. So kindly sit back, relax, and we hope that the session will be liked by you. Before we start the session, as a customary, we would like to kindle the light of joy. They say that while the prayers go up, the blessings comes down. May I request today's dignitaries, Dr. Iqbal Jahan Madam, Yani Madam, Dr. Anita Ma'am, to kindly come forward to light the lamp and inaugurate the sessions.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समान.
Thank you so much, ma'am. We totally appreciate your time in spite of your me time on a Sunday morning. You have decided to come and be part of our conclave. Before we move on to our scientific session, I would request Mr. Sudhakar Jadhav sir, who is our Chief Operating Officer for Oasis Fertility, to speak a few words about Oasis Fertility journey so far. Over to you, Mr. Sudhakar, sir.
Thank you so much, ma'am. Thank you so much. I know it's going to be an interesting session for all of you. I'm not going to stand between the scientific sessions, but I thought it's my duty to talk a little bit about Oasis Fertility. Can I have the slides, please? Sure. Well, so next few minutes I'm going to speak about Oasis Fertility. Oasis Fertility, the beginning was made in 2009. Very humble beginning with one clinic in Banjara Hills, which was for us, I think last 4 years have been very exciting. In last 4 years, we started as one single clinic way back in 2009, and then we started our journey, started a center in Gachibowli, Vijay, so forth. Looking back in last 11 years, today we are strong 17 centers, and by this end of financial year will be about 25 centers. So that's the kind of growth, and that's the kind of expansion plans which we have on us. Yeah, so India map, you can see our locations here. Well, I think for us, achievements and awards have been the way of life for Oasis. I think accolades keep rolling, rolling in for Oasis. We are extremely patient-centric organization. We believe that the future of healthcare is going to be patient care. The future of healthcare is going to be, the service excellence. You take care of your patients. They are going to tell about your services to other patients. So we are extremely patient, centric as well as patient-sensitive organization. Well, talking about just this particular slides will give you a nutshell in terms of what we do. We today, we have close to about 100 clinicians with us. We have got 500 employees. Last 9-10 years, we have treated more than 35,000 couples. And I think on a yearly basis, we are talking about, more than 3,000 IVF cycles which we are doing, and then more than 12,000 cycles which we have done so far, and about more than 15,000 IUIs. Well, we are a ISO 2000 certified company. We are a NABH accredited company. We are also IVF labs. I mean, the 19, he got a healthy baby from us. So we are talking about not only about clinical fertility preservation, but also social freezing, which is on the rise because of, a lot of late marriages. Girls are coming forward to have their oocytes preserved with us. So we are talking about social fertility as well as clinical fertility preservation at Oasis Fertility. We have a wonderful platform, IT platform called Artis, which has been ingeniously built, and this is all out of our experience of last 10 to 11 years, where we track the patient's journey right from the registration till they give a live birth to the patient. So that's the kind of data of the patients which we are having. And based on this, we'll be kind of focusing on getting into artificial intelligence also. So that's the intelligence platform which we work on, right? AndroLife, I'm sure you as clinicians will agree today that fertility is just not a female prerogative right now. It's 50% issue with the males as well. So that's the reason why at every Oasis Fertility we run AndroLife clinic, which is headed by our andrologist. Dr. Raghuveer is one of them here. And last 2 years it has been a lot of response from this particular clinic, because a lot of male patients are very comfortable walking into the clinic and then talking about their issues. So AndroLife is one such solution. We talked about fertility preservation, so that's where the entire thing comes in ReproBank. In fact, I think last 2 years due to COVID has taught us a lot of lessons, but I think every industry got affected by COVID. We also got affected, but I think the wonderful part is that we were very resilient, quickly made a bounce back, quickly made a comeback. We learned from the situation, and then we put a lot of COVID safety protocols at the center. These are some of the snapshots of the COVID safety protocols, and I think last 2 years, in fact, the kind of patients walked into the center are much more than what we used to see earlier. So we started online consultations as well because of our patients were not willing to come to the center initially, but now I think it's all normal right now. And we started a very unique concept of IVF at home as well, so that the contact with the patients is very, very less, and then we try to reduce their visits of the patients by reaching out to their homes primarily. Right. So I think these are the last slides. One of our, Dr. Durga's passion is academics. For us, I think every Thursday from morning 8 to 10, 10:30, 11, we don't even run our OP there. We totally focus on academics. All the consultants, all the clinicians across the country get linked to our OSHRM. OSHRM is our school where we, give courses like FRM, as well as we got every year a couple of DNB seats also. We actually run a lot of short-term and long-term courses. Anybody who's interested, we have a counter outside. You can pick up the brochure from there. So that's all from my side. Thank you so much. I would now request Sreevani ma'am to continue the scientific session. Thank you so much. Thank you, ma'am. So while Sreevani ma'am would come up, I would like to introduce Dr. Sreevani ma'am's. Yeah. Well, Sreevani ma'am, as all of you are aware that she is our clinical head at our Oasis Center in Dilshuk Nagar. So she is a senior consultant with 17 years experience in reproductive medicine. She brings in a lot of optimism in couples striving to get parenthood. Her subject knowledge coupled with her customized approach for each patient has been very, very pivotal. Can I have the slide, please? Yeah. So Dr. Sreevani has undergone, she has done her fellowship reproductive medicine from Kraft, which is one of the pioneers. And then she's trained in various ART procedures like IUIs, IVF, ICSI scans, etc. And she has also underwent fellowship in minimal access surgery from World Laparoscopy Hospital in Delhi, and fellowship in daycare gynec endoscopy from Maharashtra, and also fellowship in gynecological laparoscopy from Germany, and has got several papers to her credit. Thank you so much, ma'am. Over to you. Yeah.
Good morning, everybody. And first of all, I would thank my teachers, my senior doctors, and my dear colleague who have taken time on this Sunday to come for this scientific session. And it is my privilege to be here in front of my teachers and giving this lecture. And Madam, thank you so much for everyone who have taken up time on this Sunday morning. So today, our ART conclave topic was its emerging trends in ART practice, and I'll be talking more about the female fertility management and emerging trends in the female fertility management. So, as we all know that the field of reproductive medicine is on like the techniques, and there are many treatments are on the very rise, and there are a lot of techniques which have come up in this last few decades. So, I think the journey so far is like in the field of reproductive journey, in the reproductive medicine is like the treatments, whatever we have, I think from ovulation induction treatments to IUI, IVF, there are so many techniques which have improved in the last couple of decades. I think we all know that in 1978, it was the birth of the first IVF baby, Louis born. And at that time, it was like they were thinking that, oh, even baby can be born without any natural intercourse. And but yes, after that, there are so many developments which have even happened in the field that so many techniques, not just IVF, even advanced reproductive techniques have come up after that. Coming to the key milestones, I think in the field of reproductive medicines, the first IVF baby, it was just a birth which has been resulted from a natural cycle. But later, I think there are so many developments with regarding to the drugs, the ovulation induction, the gonadotropins which have come up. In the first, like when they had the first IVF cycle with the birth of Louis born, it was just a natural IVF cycle, so evolved throughout these years. In the past few decades, I think not just the drugs as well as the gonadotropins and the techniques, in the past 2 decades, we had a lot of developments with regarding to the stimulations. Previously, when we used to say just IVF cycle, it was just a conventional IVF cycle. Conventional IVF cycle where we used to give drugs, stimulate the ovary, it is a controlled ovarian stimulation. But now there are even developments with regarding to the ovarian stimulation where we are not just skipping the injections to a lesser extent, and even we have come up with a newer stimulation protocols, not just a single stimulation, double stimulation in one cycle. And we have even seen the techniques of in vitro maturation, blastocyst cultures, and elective single embryo transfer rather than a multiple pregnancy, decreasing the chances of multiple pregnancy by doing a elective single embryo transfer, cryopreservation, vitrification, like the freezing of the embryos, PGTA, that is called pre-implantation genetic testing of the embryos, as well as endometrial receptivity array and platelet-rich plasma installation into the uterus. So today I think I'll be talking mostly about all these newer techniques, how it can be utilized in our day-to-day practice and help the couple achieve their dream of parenthood. I think till now I think we all might be aware that if a couple is not able to conceive with the simpler treatments of ovulation inductions and IUI, the next step is IVF. Yes. For the indications for IVF, what we usually say, it is previous failed 4 to 6 cycles of IUI, and if the female age is more than 35, male partner count is less than 1 million, and if both the tubes are blocked, and if her reserve is less, like the AMH values and her FSH values are less, yes, the indication of IVF comes into picture. Usually in a lab, what we usually do is, for an IVF cycle, we stimulate the ovaries, like based on the reserve, we do give the injection starting from 2nd or 3rd day of the cycle, and retrieve the oocytes and inject the sperm. This is the picture of ICSI what we do, injecting the sperm into the oocyte. For that, we need to have oocytes. So for retrieving the oocytes, we need to stimulate the ovary. So this is the conventional IVF cycle which has been followed up in the past for the almost 2-3 decades. So in a conventional IVF cycle, what we usually do is, it just starts from the day of the menstruation, and we usually just get the blood test done and start giving the FSH or the gonadotropin HMG injections. And to prevent the LH surge, we have to give a GnRH agonist. But in this conventional IVF cycle, the number of injections which a woman needs to take is it might go up to 10 days or 12 days. Even sometimes if they are practicing the agonist protocol, the injections might go up to even 20 days. And taking injections for more than 10, 12 days or 15 days, I think it is very painful to the woman. So yes, to get rid of all these things, the newer techniques of stimulation protocols have come into use. That is called progesterone primed ovarian stimulation protocols. As we all know, I think we need to go back to the physiology where I think we might have read in our Spearoff books that progesterone is such a hormone where it can prevent the LH surge. That concept has been utilized during the ovarian stimulation. So instead of giving any gonadotropin like antagonist or agonist during the IVF cycle, we can use just a dydrogesterone or a medroxyprogesterone to prevent the LH surge. In this way, I think a woman can just be rid of a few injections, so that she can just use only the gonadotropin injections and get rid of the agonist or agonist injections. So in this way, I think it will be very helpful, easy for the woman, and it will be less burden because we are skipping the injections, as well as the pain to the woman is also decreased. So the progesterone primed ovarian stimulation protocols are the latest development with respect to the stimulation as of now. But All these conventional IVF stimulations, everything, I think they are morely for normal responders where the woman is having a normal reserve and high reserve. But if a woman is having a low ovarian reserve, her oocytes are like the AFC is less, number of eggs are less, what can we do? Because for an IVF cycle to be successful, the number of eggs which we need is the most important factor, and the age is also the next important factor. So if a woman is having a poor ovarian reserve, I think the option of double stimulation can be discussed and can be utilized. Double stimulation is something like, I think it has been in the recent past which has been developed, where stimulation is done in two phases. In the first phase, I think it's just like a conventional IVF cycle where we start the stimulation from second or third day of the cycle and give the injection, stimulate the ovary, retrieve the eggs and create embryos. And once we do the egg pickup, we do even assess her ovaries again, and if she has a few more smaller follicles, we stimulate the ovary again. So it is like two stimulations in one cycle. And this concept of double stimulation, I think it has come up with a reason, like with the idea that the follicular wave, the recruitment of the follicle which happen is not just in a single way. It has been, because previously it has been thought that the follicles which recruit, like on second or third day of the cycle, whatever follicles which we see, it is only single recruitment. But later, I think it has been noticed and it has been told that the recruitment of the follicle happens in two phases, and we can utilize these two phases of follicular recruitment and stimulate the ovary. So this is called double stimulation, like stimulating the ovaries twice in a single cycle. Rather than just one pickup, we can do two pickups in single cycle and pull up few more eggs and create more embryos, so that the woman can have more embryos for her present pregnancy as well as her future pregnancies too. So this is more useful whenever a woman is having a poor ovarian reserve. So I just wanted to have discuss a case report. She's a woman with 34 years and AMH of 0.5, FSH 13, AFC 4 to 5 on second or third day of her period. And she had a bilateral salpingectomy done in view of her previous two ectopics. And she even had one IVF outside where she had a day 3 embryos transfer. So she's a woman with a poor ovarian reserve, with a very less ovarian reserve. So what we did is, we did stimulation twice in a cycle. So this is the first stimulation where we have created 3 embryos and we have frozen these 3 embryos. Here you could see these are the 3 embryos which we have frozen in the first cycle. And we have stimulated again after doing the first pickup. After 5 days, we start off with the tablets and injections and stimulate the ovary and do the retrieval again. And we have done the oocyte retrieval second time in the same cycle, and we have created 2 embryos in the second phase. So in the follicular phase, we have done the retrieval and frozen 3 embryos. In the luteal phase, again, we have done the retrieval and frozen 2 embryos. And she went for a transfer with 2 embryos, one from her first cryopreservation, one from her second stimulation, and we transferred 2 good day 5 blastocysts, and this resulted in a twin live birth. And still she has 3 more embryos which are frozen with us, and if she wants to have another child, she can go ahead also. So this is how I think we can help a woman who is having a low ovarian reserve have a baby with her own eggs, even though if the reserve is less. So this is one kind of a development I think we have seen in the past, in the recent decade, regarding the double stimulation. And yes, I just want to discuss another scenario. We had a woman, a 29-year-old Nalipara, presenting with a history of primary infertility, and she had a past history of cerebral thrombosis, and ovarian stimulation with hormones was contraindicated. So she's a woman who has to go for an IVF cycle, but she has a history of cerebral thrombosis where we can't give any gonadotropins, because as we give her gonadotropins, her hormones would rise. So how can we help her? Yes. The next option, what we have is in vitro maturation. So In vitro maturation is something that we, in a conventional IVF cycle, after stimulating the ovary, we retrieve the oocyte, and when we get the oocyte, it is a mature oocyte. But in IVM, what we do is, we retrieve the oocytes only when the follicle is of a smaller size, less than 12 mm, and retrieve a immature oocyte, and we mature this egg in the lab. So we keep it for culture in the lab and make it mature in the lab. Once it is matured only, we do the ICSI onto the matured egg. So this is called in vitro maturation. So this is how IVM cycle is done. In IVF cycle, usually in a what we do is, like compared to the conventional IVF cycle, where we need to give a lot more injections, like around 10-12 days. In IVM cycle, we are only just 3 to 4 days of gonadotropins are given, and once the 3-4 days of injections are given, we retrieve the eggs and we retrieve the immature oocytes, and we keep it for culture in the lab. I just wanted to show the picture. This is how the oocytes look. Here you could see these are the immature eggs what we get in an IVM cycle. Usually when we do a IVF, we retrieve a mature egg, but in IVM we get a immature egg, and this immature egg is kept for culture and it put for maturation in the lab for 24 to 48 hours. And once by adding the certain and Dr. Krishna will be talking more about the IVM media, how we do the maturation in the lab, and once it reaches a mature egg, we do the ICSI. So this is how IVM can help a woman who can't take injections, but yes, still she needs to go for a IVF cycle. So these are the indications for an IVM would be a PCO woman who is who is at a very high risk for ovarian hyperstimulation. Yes, instead of giving injections and stimulating her ovaries and creating more number of eggs, we can just do a IVM and retrieve the immature and oocytes and mature them in the lab. And patients with poor response to IVF stimulation, if they had any IVF cycle prior and they didn't respond, yes, IVM would be the next option. And as I told you, if she has any history of cerebral venous thrombosis where gonadotropins can't be given, IVM would be the next option. And yes, as part of fertility preservation, like estrogen sensitive cancer, where we can't give any injections, gonadotropin injections, where there is a risk of increase in the estrogen, IVM can be suggested to those couples, and they can have a baby. Yes, coming to, as I told you, as a part of fertility preservation, how we do control ovarian stimulation in breast cancer patients, because I think everyone might be aware that in breast cancer patients, we need to keep the estrogen levels as less as possible. So if the woman has come on second or third day, we just start off with anti-estrogen, letrozole, and stimulate the ovaries and keeping the hormone level as low as possible, so that she might not be having a risk of high estrogen level because of the breast cancer. But not always, I think, women can present to us on second or third day, and we can't wait until she gets a period, because once she's diagnosed with a cancer, we can't, and when she needs to go for a chemotherapy or radiotherapy and she wants to preserve her oocytes, we need to stimulate her when we need. So at that time, I think we can start with a random stimulation, and this is how we start. Random start in late follicular phase, rather than just waiting for the period. When she comes, I think we can start off, and by giving a letrozole and retrieving the oocytes. And even if she comes in the luteal phase also, as I discussed, the concept goes with the double stimulation concept. We can start off with the injections even in the luteal phase. So the stimulation has changed a lot, that we don't need to start the cycle only when we see where she gets a period. So if we need, we start on an emergency basis, we can start on at any day of the cycle irrespective of her menstruation. So this is the concept regarding the random start, where I think it is very much useful for a woman who wants to go for a fertility preservation with respect to any breast cancer or any cancer, if she is going for any chemotherapy or radiotherapy and wants to freeze her gametes. So this is how, and this is a case report. I think 32-year-old with a case of secondary infertility, regular cycles, and with the carcinoma breast, ductal cell carcinoma. Patient was awaiting chemotherapy and followed by surgery and radiotherapy. So she wanted to freeze her gametes. So that is how. So the plan was to do IVF before her further treatments. And husband side, it was completely normal, and she had an AMH of 18 picomoles. AFC was also good. So she presented on like in the late follicular phase, so we had to stimulate her, and on day 15 of cycle only one oocyte, because she had, it was a natural cycle, only one egg was there, we retrieved one oocyte, and that was immature, but we kept for IVM. But it matured, the XC was done, but it didn't cleave. So what we did a double stimulation for her. The second retrieval was done 7 days after giving letrozole again. And here we got 5 oocytes, and we have kept them for IVM. And she has 3 embryos frozen with us. One is day 6 and other are like day 3 and day 4 transfer. The embryos are still frozen with us, and we are waiting for her to come back after she finishes her chemo and radio. She can go with her transfer of these embryos later stage. So this is how I think we can help a woman who needs to preserve her gametes, and who is also going for a chemo radiotherapy, and help her out to achieve a baby with her own gametes. As we see that after a chemo radio, once we start chemo radiotherapy, the ovarian reserve comes down, the number of eggs comes down, the quality comes down, and she might not have a chance of having a baby with her own gametes. But yes, doing a fertility preservation before going for a chemo or radio will help her to achieve a baby with her own gametes in a later years once she comes back after the treatment. Because today I think we are seeing a lot of change in the cancer treatments, that the survival rates for a woman after cancer treatments have increased. So she can have a baby later on with her own gametes if they are frozen prior. So I think till now we have spoken about the stimulation protocols and how we can help a woman in different case scenarios. So I think now we will move forward to the next thing, that yes, many of us, I think we might be aware that, okay, one of the women, she had an IVF cycle, but it failed. Most of the women or a couple think that, yes, I had an IVF cycle, it did fail, there is no chance of having a baby later. But no, there are still more lot of options a woman can have even if she have one failed IVF. So because we need to analyze what was the problem in her previous IVF cycle, where did the problem have lied. So we need to analyze her previous IVF cycle, what was the stimulation protocol, how many eggs did she had, what kind of embryos were transferred, what was the factors with respect to the male partner, everything. So based on that, we help the couple having a baby with her own after even if she had a IVF, one failed IVF. So the concept of, I think, blastocyst culture and transfer comes into picture here. As we all know, even in a natural cycle, once the ovulation happens, in the fallopian tube, the fertilization happens. After the fertilization, the progression of the embryos happen. So the same kind of a thing we do even in an IVF cycle. So this is a picture of the embryos in an IVF lab, how they look. So this is on the day 1, the fertilization check, how the male and female pronuclei look. This is on day 3, where there are 6 to 8 blastomeres are seen. And day 4, we are seeing a morula, and day 5, it is a blastocyst. So as we all know that even in a natural pregnancy, the embryo attaches or implants onto the uterus only when it reaches the blastocyst stage. So even in a IVF cycle, we try to culture the embryos till day 5, a blastocyst stage, then do the transfer. In this way, we are increasing the chances of the woman achieving a pregnancy. Because when we see a day 3 embryo, not all embryos might have a potential to move forward toward day 5 stage. So that is the reason we need to culture the embryos till day 5 and pick up the best embryo for transfer and do the transfer. One of the case scenario, I think she's a 36-year woman with primary infertility, marital life 9 years with PCO, male factor oligoastenospermia, and she had 2 failed IVFs outside. In the first cycle, she had 4 day 3 embryos transferred. In the second cycle, she had 3 day 3 embryos transferred, but in spite of that, she didn't had a positive pregnancy. So how can we help her? Yes, What we did, we stimulated her and we created embryos. We cultured till day 5 because she had a day 3 transfer. This time what we did is we cultured the embryos till day 5 and she went for a transfer with 2 blastocysts, beautiful blastocysts, and this resulted in a twin pregnancy. So that is how I think that I just wanted to emphasize that one failed IVF is not something that the woman can't have any chances of pregnancy later. There are chances and we can help her out having a baby with her own. Yes, and at Oasis we do most of the transfers are blastocyst transfers. Yes, sometimes as we even see that a woman had a blastocyst transfer, but still she didn't had a pregnancy, or else if she had a recurrent pregnancy loss, how can we help her? Yes, the answer to that is, as we all know that for a failed IVF cycle or in a, or else in repeated miscarriages, one of the most common reason for miscarriages or embryo not implanting into the uterus is aneuploidy in the embryos. So we can test whether the embryo is normal or aneuploid prior to transferring the embryo into the uterus, and the answer to that is PGS. PGS, so that the latest terminology is PGTA, pre-implantation genetic testing for aneuploid is what we call. Here what we do is we biopsy the trophectoderm. We just do a laser shot, do the biopsy of the embryo, take out a small cell and send it for testing, and this we do analyze the embryo for the complete 23 pair of chromosomes, and we, with this we can know whether this embryo is genetically normal or not. And but this is how the process goes on. We do the egg pickup, we create the embryo, we send it for testing, and once the report comes, if at all we have 3 or 4 embryos, and the report would be generated showing us whether it is euploid, aneuploid or mosaic embryos, only the euploid embryo is taken and put into the uterus back. So in this way, we can just help a woman who had a failed transfer, or even with a blastocyst transfer, it didn't implant. Yes, checking the embryo for the genetic component and transferring the genetically normal embryo into the uterus would help her achieve a pregnancy with her own gametes. Most of the time, I think couples do come to us saying that I had 2 cycles of IVF done outside, it failed. We just want to go for a donor cycle. But no, the answer is definitely no. There are so many technologies and developments which have happened that even if they had a failed transfer, the answer would be that going with their self gametes and achieving a pregnancy with their self oocytes and self gametes. So this is how we helped a couple doing a PGS. So there's a case report. Primary infertility, 30-year-old woman with 8 years marital life and 1 failed IVF cycle. Yes, even she had, after 1 cycle of IVF, they have frozen, and she had 2 times transfer, frozen embryo transfer. And both the times they did a blastocyst transfer, but it didn't work for her. So what we did is, we did stimulation, we created embryos for her, and we got 3 blastocysts for her. And this is a report of her PGTA. We have sent these, what the embryos we got, the 3 embryos we have sent it for testing, and this is a report of the 3 embryos what we have got. Out of 3 embryos, only 1 embryo came out to be genetically normal, and we can transfer only this single embryo into the uterus. So we did the transfer with this single embryo, and it resulted in a singleton live birth. So this is how I think we can individualize a case and help a woman or a couple who had a failed IVF cycle previously. And yes, I think as I was speaking, if a woman had a recurrent pregnancy losses or recurrent miscarriages, what can we do? Yes, I think if they had conceived naturally, we can just support with a complete support, giving equosprin, low molecular weight, but sometimes if there is a genetic issue, they might still miscarry. So the answer would be yes, even we can help them out by doing a PGS to the embryos. Here the woman, she's 38-year-old, marital life 14 years, and AMH of 0.5. So already she has very poor ovarian reserve, and she had 2 miscarriages prior. And after that, she even had 6 failed IUIs, but didn't result in a pregnancies. So for her, we did a IVF stimulation. We created 4 embryos. We sent those 4 embryos for testing, and out of 4 embryos, only 2 came out to be normal. And she chose to go with a transfer of single embryo for at the time of transfer. And out of the 2 genetically normal embryos, we have put back 1 PGS normal embryo, and still she has 1 more embryo which is left with us. And that single embryo, it resulted in a live birth, and she still have 1 more embryo with us, and she can go for a second pregnancy. So yes, at the age of 38, with a history of 2 miscarriages, and with a history of 6 failed IUIs, and thinking that there is no chances later on, yes, she had a live birth with her own gametes, and still she has 1 more embryo which is frozen with us, and she's planning to have a transfer in I think next year once she comes back to have a transfer. So yes, these are the answers I think we can say to the couple or help the couple by saying these are the developments with respect to the field of fertility which has emerged in the last couple of decades. I think till now we have just spoken about the aneuploidies in the embryo, but sometimes we even see that some genetic issues even run in the family, and the couple might be very much worried, like they want to have a baby without the particular genetic disease which is running in the family. So the answer to that would be PGD, like diagnosing a genetic disorder which runs in the family by testing it prior and putting back a normal embryo which doesn't have the disease. So this is called PGD. This is a case, I think, the indications for PGD, yes, if the family history of any cystic fibrosis, Tay-Sachs, spinal muscular atrophy, hemophilia, sickle cell disease, Duchenne muscular dystrophy, thalassemias, if there is a history of any of these disorders, and the couple want to have a child without any of these genetic issues, the answer would be PGD cycle. Like we can test the embryo whether it is having any issue or any of these genetic disorder. Only the embryo which is completely normal, devoid of these genetic disorders, will be put back into the uterus, and the couple can have a healthy baby devoid of these all genetic disorders. And even sometimes I think the previous baby might have had a genetic issue and they want to have a second child without any of these disorders. The answer would be PGD. This is another case scenario, a 24-year-old female, secondary infertility, 5 miscarriages, all were first trimester miscarriages. RPL profile, like the complete recurrent pregnancy loss profile was done, everything was done, all the antiphospholipid antibodies, the protein C, protein S, everything was done, everything was normal. But in the karyotype, the male karyotype showed translocation. So because of translocation, we have offered PGD for them, and 5 blastocysts were formed, and we have biopsied these 5 blastocysts, and only 1 embryo came out to be normal. And we have transferred this 1 single embryo, and the couple had delivered a healthy baby girl. So this is how, yes, even with the translocation and with a history of recurrent pregnancy loss, a couple can have a baby with their own gametes by just going with the advanced fertility treatments. And in another case scenario, where I think they had 2 failed ICSI cycles, and here they never had because even though had the 2 failed IVF cycles outside, they didn't had a karyotype. So we had done a karyotype, and the karyotype had showed a inversion. Even here the PGD was done, and we had only 1 normal embryo which has got, and we transferred that, and it resulted in a normal healthy baby. So translocations, inversions of the chromosomes, for all these, one of the answer would be PGD. So yes, we were many times, I think we do even hear that the couple had multiple IVF failure and multiple cycles of transfer of best embryos. Still the embryos didn't implant and never had a pregnancy prior. So how can we help them? So this is called recurrent implantation failure. Means they are getting transferred of a very beautiful embryos, but those embryos never implanted. So how can we help them? Yes, one of the option would be by testing the embryos by doing a PGTA. like knowing the genetic component of the embryo. But sometimes even we put back a normal embryo, the uterus might not be receptive to receive the embryo. So the answer for that would be to do a endometrial receptivity array. So endometrial receptivity array is something that we are knowing the exact time where the uterus is ready to receive the embryo. Normally, in a conventional IVF, what we do is, whenever we do the transfer of the blastocyst embryo, we start the progesterone, and since it is a day 5 embryo, we do the transfer 5 days after start of progesterone. But in some women where there is a derangement of the endometrial receptivity, even if we put back a beautiful embryo on a day 5, like 5 days after start of progesterone, 120 hours, the endometrium might not be receptive to receive the embryo. So in that case, yes, the option of endometrial receptivity array would be given to them. And so this endometrial array, what it does is, it will be checking the 238 genes which are involved in the receptivity. So it will tell us when exactly the uterus is ready to accept the embryo. So this is how the report gives, like whether the endometrium is pre-receptive, whether it is receptive or a post-receptive. So based on the report of the endometrial receptivity array, we do the transfer. So how we do? We just do as we just do the preparation for the frozen embryo transfer cycle. We do give a HRT like estrogen for 12 to 14 days and start a progesterone. And once we do the start the progesterone, 5 days later we are supposed to do the transfer. But what we do is, after 5 days of progesterone start, we do take a biopsy of the endometrium and we send it for testing. And that report will give us whether that endometrium is receptive at that particular time or not. So we do take 2 biopsies, one on day 5, one on day 6, and the report would give us the exact time. It is called more of a personalized embryo transfer. So this is a case report where a woman had previous biochemical pregnancy, 1 ectopic and 1 miscarriage with an AMH of 0.9. And here I think we can see that she had 3 failed IVF cycle with her own gametes outside. And since it didn't work, she even had a IVF with donor eggs for 3 cycles more. Self 3 cycles, donor 3 cycles, all of them didn't result in a pregnancy for her, but she had a natural pregnancy prior. So if we did a karyotyping, everything was normal. So after 6 cycles of IVF done outside, she wanted to have a baby with her own oocytes. So the answer, like what we did is, yes, we did the IVF stimulation with her own eggs. If at the age of 33 with the AMH of 0.9, we did a stimulation with her own oocytes. We created 3 embryos, we got 3 blastocysts, and we sent these 3 embryos per PGTA. And the report what they have given is, she had 2 normal embryos. So, and later we have done an endometrial receptivity array for her, and the endometrial receptivity day 5 report, it has given that this is the report, like conventionally, like for everyone what we do the transfer time, this is the 120 hours time. So this has come out to be pre-receptive. So if we would have transferred at this particular time, even if I would have put back a PGS normal embryo, it might not have given her a positive pregnancy rate. But yes, the second biopsy on day 6, it has like even at 144 hours, it has given that it is at the end of the receptivity phase. And they have suggested that her transfer should be performed at 132 hours after the progesterone administration. So they give us the exact time where we can do the transfer. So if I would have transferred at 120 hours, if I would have transferred at 144 hours, even if I transferred a PGS normal embryo, it might not have resulted in a positive pregnancy. So the endometrial receptivity array, they have suggested to transfer at 132 hours. So we did transfer 1 PGS normal embryo at 132 hours after progesterone start. And this woman, after 6 failed IVF cycles, 3 with self, 3 with donor outside, she had a baby with her own eggs after I think a very long waiting time. So this is how I think the advanced techniques, if we can offer and help a woman taking them, and we can just help a woman have a baby with her own gametes at the end. So this is one of the case scenario what I wanted to discuss. Yeah, coming to the next thing, we had a doctor who was unmarried, but she wanted to plan her family 5 years later. And in one more case where she had an endometrial adenocarcinoma, but she wanted to have babies later. So the option, what the help we can give is like freezing her own eggs. So fertility preservation, egg freezing. So the couple, the woman who wants to freeze her eggs just to postpone her family, that is called social freezing. But yes, in another case scenario, she had adenocarcinoma, but after she wanted to go for the surgery and chemo radio, but she wanted to freeze her own gametes. So in that case, it is called clinical fertility preservation. So with the help of fertility preservation, we can help a woman freeze their gametes and plan a baby later on with her own gametes. So this is I think we are seeing in lot that women are delaying their pregnancy and planning their pregnancy at a later stage. So yes, for them who wants to delay their pregnancy but want to have a baby which is completely normal, devoid of any genetic issues, yes, if they can freeze the oocytes prior, even if she is planning a baby at 39, she can have a baby with the egg which has been frozen at 30 or 32. So which would be devoid of any genetic issues later. Yeah, and why we need to emphasize means, as we all know that the miscarriage rate, the aneuploidy rate, once a woman reaches 35 years, it is it increases, and the trisomies are on the rise. So yes, who wants to delay but wants to freeze, the option of fertility preservation can be given, and they need to even explain properly that with the age, the fertility rate, the chances of conception decreases. So yeah, even if they want to delay, they can just freeze the eggs and plan babies later on. And yes, with respect to the cancer treatments, before planning any surgery, they can go with the fertility preservation of their self oocytes. And the ASRM guidelines, what it says is cancer specialists should inform patient about the options of fertility preservation, and they should refer them to the fertility specialist at the earliest. And they need to be counseled that yes, there are options, even if she's going for any chemotherapy, she can freeze the oocytes prior. And prior to any cancer or chemo radiotherapies, they can go with this preservation of their self gametes. And yes, physiological aging, premature ovarian aging, and yeah, even if sometimes if we are seeing a young woman with severe endometriosis, she's young, she had a huge endometrioma, but later down, as we all know that with endometriosis, the number of eggs comes down, the reserve comes down. The option of freezing the eggs prior can be given in these kind of cases. So this is respect to the regarding the fertility preservation. And the options for fertility preservation at Oasis, we do immature oocyte retrieval, by doing a IVM, and we even do the oocyte vitrification, where we take the immature eggs and freeze them. Sometimes if the woman is married, we can do the ICSI and freeze the embryos prior. And sperm freezing if the male factor has some issue. And coming to the next thing, I think still now we have spoken more about ovaries, stimulation, everything. Yes, so what new we have with respect to the thin endometrium. Whenever we see a woman with thin endometrium, the first option comes into our mind is giving a HRT, like high dose estrogen, vasodilators, but sometimes even by giving all these things, the endometrium might not pick up. So at this point of a time, the option what we have is by doing a PRP installation. Here we have a woman. She is 27-year-old with a primary infertility with a bilateral tubal block, but with a very thin endometrium. She just had only 4 to 5 mm of endometrial thickness. So what we did, because of the bilateral tubal block, the option for her was only IVF. So we did IVF. We froze 8 embryos blastocysts for her. And since she had a thin endometrium, We did a hysteroscopy. This is a picture of the hysteroscopy where we could see the flimsy adhesions. The cavity was completely of flimsy adhesions. All these are the flimsy adhesions what she had. And post like adhesolysis, this is the picture. And what we did at the time of hysteroscopy, we did a subendometrial PRP instillation. So we injected the platelet-rich plasma into the subendometrium at the time of hysteroscopy under ultrasound guidance. So after that, the woman who had a thin endometrium of just 4 mm or 5 mm, so after giving the next, we took her for the frozen embryo transfer, and the endometrium picked up to 6.9, nice 999. So we gave her HRT like estrogen, estrogen of 2 TDS, and even with the vaginal estrogen we have supplemented her with. Later we have given her vasodilators, and after giving a vasodilators, we again did a PRP installation into the uterus as we do a IUI, and the endometrium picked up to 6.9 millimeters, a nice 999, and we transferred 2 good blastocyst embryos into her uterus with the endometrium of only 6.9. And yes, after that, both of the embryos implanted, and she had a twin live birth. So this is all, I think these are all the case scenarios and the treatments and the advanced treatments, I think, what we have, and where we can help the couple or a woman use them and achieve a pregnancy with their own gametes. Either it would be a oocyte, either it would be as a sperm, and we can help the couple achieve a pregnancy with their self gametes. So, and the motto of Oasis would be helping a couple to have a baby with their self gametes rather than going for a donor. Donor, I think they can go at any age of their cycle, but having a baby with the self, if a woman is of elderly age and with so many complications, by adapting to the advanced treatments what we have, we can help the couple have a baby with, at the end with their self gametes. So with this, I think I would end my talk regarding to the advanced treatments, and thank you very much.
Thank you very much, ma'am. If there are any questions, probably we can take it now or later. Sure. I would call upon our next speaker, Dr. Raghuveer Karne, who is a renowned urologist come andrologist in Hyderabad, and he has got more than 7 years of experience, and he is now pioneering in male fertility. He has been with us for some time now. Dr. Raghuveer has done his MBBS from NRI Medical College Guntur and MS General Surgery from JJM Medical College Davangere, and he has also done his DNB in genitourinary surgery from Kamineni Hospitals, and he is a trained clinical andrologist. Dr. Raghuveer also received micro TC and micro varictolomet, and he is concentrating on treating and researching on erectile dysfunction as well as spermatology. Thank you so much, and I request you to take from here.
Thank you, sir. Thank you for your kind introduction. Okay, so good afternoon, everyone. So today I would like to discuss about the microsurgical treatment for the male infertility. So the first case, so it's a 28 years old male with a 25 years old healthy female, so no significant medical history, and they presented with primary infertility. So he came with a semen analysis report showing 3 ml volume with 7 million sperms and motility of 18% with 2% normal forms. So what's the next step? The first would be the physical examination, and next would be the repeat semen analysis. So ideally semen analysis should be done in an andrology lab with the trained personnel. We need to check for the reliability of the report with which the patient come. So on examination, we found to have a large varicocele, and the repeat semen analysis was 3 ml with 9 million and 22% motility sperms, and the morphology was 2%. So this is the slide showing the updated WHO 2020 semen analysis parameters. So in this, the semen volume should be 1.4 ml and the concentration should be 16 million, and total motility should be 42%, and the progressive should be 30, the viability should be 54, and the morphology should be 4%. So coming back to our case, so this is a 28 years male with a 25 years old healthy wife. Both the semen analysis reports are abnormal, and he has a large varicocele. So varicoceles are dilated veins in the spermatic cord. To be more specific, they are the pampiniform plexus of the veins. So how do varicoceles cause male infertility? So varicoceles can affect the endocrine factors, that is, they can cause the hormonal imbalance, they can cause testicular hypoxia, scrotal hyperthermia, and reflux of metabolites from the adrenal vein, and also cause cadmium accumulation. So all these things can impair the spermatogenesis and elevate the reactive oxygen species. So these in turn can increase the sperm liquid peroxidation, DNA fragmentation, and apoptosis of spermatozoa, so which can decrease the male reproductive potential. So how do we classify the varicoceles? So they can be clinical and subclinical varicocele. So clinical varicoceles are palpable varicoceles. So grade 3 are large varicoceles which are easily visible. Grade 2 medium varicoceles which are palpable at rest without any Valsalva maneuver. So grade 1 they are palpable with Valsalva maneuver, they are small varicoceles. So subclinical varicoceles are not palpable, so it's an ultrasound finding. The veins can be larger than 3 mm on ultrasound, and even they can have reflex on the Valsalva maneuver. So it's important to note that we need to treat only clinical varicoceles, not the subclinical varicoceles. So what are the indications for varicocele repair? So the varicocele should be palpable, and the couple should have documented infertility. The most important factor is that the female should have normal fertility or potentially correctable infertility. So particularly in females with low ovarian reserve and advanced age, IVF would be better option than like waiting for varicocele repair. And because after varicocele repair, we need to wait for 3 months for the semen parameters to become normal. And the male partner should have 1 or more abnormal semen parameters. So does the varicocele repair improve male infertility? This is one of the largest randomized controlled trial. They concluded that the varicocelectomy is superior to observation in infertile men with palpable varicoceles and semen, impaired semen quality. And the spontaneous pregnancy rates were 14% in control group versus 33% in treated group, and the odds ratio was 3, and the number of patients needed to treat for one clinical pregnancy is 5.27 patients. Similarly, varicocele repair can improve IUI success rate. This is a study by Dietz et al. And the live pregnancy rate was 32% in the treated couples and 4.2 in the untreated couples. And the odds for pregnancy was 4.4 higher than the times higher than that of treated couple, and odds for live birth was 13% higher than that of treated couples. So similarly, varicocele repair also improves the ICSI outcome. So this is a study by Sandro Stevestos, and there is a statistical improve in sperm count and improve in motility of the sperm. The pregnancy rate was 73% in the treated couple compared to 48% in non-treated couple, and the live birth was 51% in treated couple compared to 37% in untreated couple. So varicocelectomy also decreases DNA fragmentation rate. So these are few studies which concluded that the varicocelectomy can decrease the DNA fragmentation rate and in turn increases the ICSI success. So how do we treat the varicocele? The most commonly used methods are embolization, microsurgical varicocelectomy, and laparoscopic varicocelectomy. So this is the table showing the different techniques for varicocele repair and the complications associated with that. So of this, the microscopic inguinal or subinguinal varicocelectomy appears to be the best procedure. because in this artery is preserved. As we use vascular Doppler, we can preserve the artery, and the chance of hydrocele formation is 0 because under microscope we can identify the lymphatics and spare them, and the failure rate is also less compared to other procedure, and there are no serious morbidity in these conditions compared to other procedures. So microscopic subinguinal or inguinal varicocelectomy appears to be the gold standard technique for varicocele repair. This is the picture taken during the surgery. So in this the magnification was 16x. So ideally varicocelectomy should be done under microscope. So under microscope we can identify the veins and we ligate and cut it. And this is the vascular Doppler used for it. So with this we can identify the testicular artery and preserve the artery. So moving to second case. So a 33 years old healthy male with a 31 years healthy wife. He presented with azoospermia with bilateral small testis. It's a 4 cc testis. Usually the normal volume will be around 15 cc. So we have done hormonal evaluation. The FSH was 25. So it was raised. LH was 5, which is normal. Testosterone is normal, and prolactin and estradiol were normal. So what's next? So next step would be to differentiate whether it's an obstructive azoospermia or a non-obstructive azoospermia. So is there a role of testicular biopsy to differentiate between obstructive and non-obstructive azoospermia? So this is a very good study from Skoor et al. They have concluded that 90% of the men with non-obstructive azoospermia have FSH greater than 7.6 and testicular long axis less than 4.6 centimeter. So high FSH with small testis, azoospermia is likely to be production defect, that is non-obstructive azoospermia. So now no diagnostic biopsy is needed for this. We can just based on the FSH and testicular size, we can come to a conclusion whether it's an obstructive or non-obstructive azoospermia. So in this patient, the patient has azoospermia, bilateral small testis, and FSH is 25 elevated. So more likely the diagnosis would be non-obstructive azoospermia. So what's next? So is there any role of medical therapy in this treatment in this patient? So coming back to hormones, his FSH was 25, LH and testo are normal, estradiol is normal. So all the parameters are normal. So there is no role of any medical management in this patient because usually medical management is given in a patients in whom the testosterone is less. So in this patient there is no role of any medical management. So next would be the genetic testing. So who should be offered the genetic testing? So who should be offered the genetic testing? So the men with sperm concentration less than 5 million, Y chromosome microdeletion and karyotyping should be done. And whereas men with absent VAS or idiopathic genital obstruction, CFTR testing should be done. So with a sperm count less than 5 million, Y chromosome microdeletion and karyotyping, with 0 sperms, that is azoospermia, again Y chromosome microdeletion and karyotyping. Whereas in patient with absent VAS or idiopathic obstruction, CFTR has to be done. So no patient requires all the 3 testings. So coming to the Y chromosome has a long arm and short arm. The short arm is YP and long arm is YQ. So the long arm contains 3 areas, that is AZF, A, B and C areas. So in AZF A deletion, the pathology usually will be germ cell aplasia and there won't be any retrievable sperms in these patients. Whereas in AZF B, the pathology would be maturation arrest and there is no retrievable sperm in these patients also. Whereas in AZF C, there is a chance of hypospermatogenesis, so there is chance of retrieving sperm with microTCA. So ideally in a patients with AZF A and B, we should offer with donor or adaptation. In AZF C, we can go ahead with microdissection and can plan IVF. So coming to karyotyping, the most common karyotyping abnormality would be Klinefelter syndrome, that is 47XXY, and the features would be reduced testicular volume and increased FSH and LH and low testosterone with symptoms of hypogonadism. And 90% of the patients present with azoospermia, less than 8% patients can have few sperms in their ejaculate. So what's the next step? So is there any role of testicular biopsy in the management of non-obstructive azoospermia? So the answer is no. So these are the guidelines from American Urology Association. So the testicular biopsy is not necessary for diagnosis or prognosis of non-obstructive azoospermia. So patients who have normal FSH and normal testicular volume should undergo diagnostic testicular biopsy, because normal FSH doesn't assure the presence of normal spermatogenesis. So what are the different pathological variants in non-obstructive azoospermia? One is hypospermatogenesis, the other is maturation arrest. So in maturation arrest, we won't find mature sperms, only primary spermatocytes which are seen as round cells are seen. And the third is Sertoli only cell syndrome. So in this, the tubules just contain Sertoli cells. There won't be any germ cells in this. So prior biopsy and microdissection TSA. So this is a very good study by Ramaswamy et al. So usually without a prior biopsy, the retrieval of sperms in Sertoli will be around 51%, whereas with prior biopsies of 3 to 4, the retrieval comes down to 11%. Whereas in maturation arrest, the retrieval would be around 83% without prior biopsies, and with biopsies, it can come down up to 20%. Similarly, in hypospermatogenesis, the retrieval can come down up to 66%. So success of micro TSA after prior unsuccessful biopsies will definitely come down. So unindicated diagnostic biopsies can impair the sperm retrieval success in micro TSA. So coming back to our scenario, so this patient, he came with a biopsy report of Sertoli only cell syndrome, and his karyotyping and Y chromosome microdeletion were normal. So genetics were normal. So what next? So the next would be the surgical therapy. So what are the different methods of surgical therapies? One is fine needle aspiration. So other is percutaneous biopsies. The next is open biopsy, and the other is multiple open biopsies. So it's important to note that not all the sperm retrieval procedures are same, because the least invasive would be the testicular sperm aspiration, and the most invasive would be the micro TSA. So despite being the most invasive method, so micro TSA is the one which has high success rate of sperm retrieval. So what's micro TSA? So the concept behind micro TSA is that with the microscope we can identify the sites of sperm production without removing the large areas of testis. So this was the concept put forward by Schlegel in 1999. So how do we do micro TSA? So we do the bivalving of the testis. So under microscope around with 25x magnification, we look for the advanced stages of spermatogenesis. So usually the tubules which are larger with normal architecture, they usually contain sperms. So in this picture, the red circle shows the collapsed tubules, whereas the white circle shows the dilated tubules. So these dilated tubules are likely to harbor the sperms. So under microscope, we pick up these tubules and check for the sperms. So effects of micro TSA compared to conventional TSA. So in this study, they have compared micro TSA with conventional TSA using ultrasound. So to the surprise, they found that the changes with micro TSA are less compared to the conventional TSA or biopsy. So what happens to the testosterone after TSA? So usually the testosterone drops down in initial 6 months, maybe within 1.5 to 2 years, they usually become normal. So it's completely safe procedure. So what's the effect of FSH on the sperm retrieval? So usually we are in the opinion that high FSH, the chance of retrieval will be less. So this is a very fine study from Ramaswamy. To their surprise, they found that the sperm retrieval chance is less in a patient with FSH less than 15, whereas it's high in FSH more than 20-25. So high FSH is definitely not a contraindication for micro TSA. So how do we manage the testicular tissue specimens? So we look for sperms in the tubules. So the dispersion can be mechanical dispersion. If you can't find sperms in mechanical dispersion, we can do the enzymatic dispersion with collagenase and RBC lysis buffer, and we can also incubate the sample with pentoxifillin. So this is the data from Oasis. In the past 1 year, we have done around 70 cases of micro TSA, and the sperm retrieval rate was 65%. So to conclude, varicosilectomy can improve the natural conception and also ART outcomes. and men with non-obstructive azoospermia have heterogeneous pattern of sperm production. So the diagnostic biopsy has a limited role. It should be offered only in patients with normal FSH and normal testicular volume. And micro-rotation is the gold standard technique for sperm retrieval in non-obstructive azoospermia. So thank you for your patient listening. Thank you.
I would welcome Dr. Krishna Chaitanya, sir, our Chief Embryologist and Scientific Head at Oasis Fertility, to take the dais.
So, morning everyone. So I think I'll not get into too much into clinical aspects. You've had Dr. Sreevani and Dr. Raghuveer present a lot of clinical aspects. But I thought I'll take you briefly through the emerging trends in the laboratory. There's so much that's happened in the last 4 decades in terms of the laboratory science. I think if you're talking about an IVF setup and IVF treatments, I think the embryology lab is really playing an important role. Without these advancements in the embryology laboratory, I don't think success would have reached this point. So it's just a brief thing that I'm going to take you all through this journey. So 1978, the first birth of an IVF child way back in UK, Louis Brown is the baby she's called. It's been 4 decades. There's been amazing advancements in terms of science, technology, a lot of it. What we're seeing today is a tireless journey, research, and a lot of advancements without which I don't think we would be able to give the success what we're giving. Way back in 1978, the success probably was around about 6%. And today, we're talking success close to 60 or 70%. Yes, we still can't guarantee 100% success with IVF, but we have emerged to come to a point of 60% success. And thanks to the science and technology that's evolved, and I'll quickly take you through those various technologies that are helping us. And all of this data that we are presenting, we've managed and done our best to publish it in a lot of international journals. All of this is done at Oasis, and I'll quickly take you through all of this. So let's start with the ovary and oocytes. So what are the latest trends and advancements that have really helped us improve the success rates? So Dr. Sreevani took us through a lot of case scenarios and this. So oncofertility, fertility preservation. I think for the fertility preservation to evolve, I think the trend or the advancement that helped was vitrification. Cryopreservation, the cryobiology in the last few decades has remarkably improved. Now we can freeze anything. We've got survival which is close to 95 to 98%, fresh or a frozen tissue. There's no difference, and that's actually safe, and there's no effect on the outcome of the neonates. So a lot of advancement has happened with fertility preservation, which is helping all the onco patients. It's just not the oncology patients, a lot of transplant patients also come. Thanks to all the onco institutes and the transplant units across Telangana and Andhra Pradesh who send these patients to us even before they undergo any treatment. We do offer fertility preservation. That's really helped a lot of couples complete their journey of parenthood. So what ideally happens in fertility preservation is, we take the ovarian cortex, we make small little pieces like that, and then we kind of preserve it, and whenever the lady is wanting to start with her childbearing plan, we then do an auto transplantation, and then the eggs are taken, and then we do the cycle. What's interesting is the next level of this. Now that we can preserve the ovarian cortex, a lot of groups around the world are wanting to use this as an alternative for hormone replacement therapy. So we all know postmenopausal, there is a need for HRT for a lot of reasons. So we could actually, in women who are at a higher risk of complications, we could prematurely preserve the ovarian cortex, later do a transplant, and that can be an alternative, and it's a safe, natural way. Still we're trying to look at validating it, but that's a wonderful concept that's coming up, where we could actually get away with a lot of complications of HRT. And of course, oocyte freezing, Dr. Sreevani made my job easy. A lot of it, that's been happening. As a fertility clinic, oocyte freezing or oocyte vitrification, you know, all those indications are there. It's made one job for clinicians and embryologists easy, is especially the donor cycles. It's not that we want to advocate a lot of donor cycles, and we have shown how we really work and ensure that we try and give a self-gamete conception to the couples who come to us. With donors, what happens is, you know, trying to match a donor and recipient, you know, getting two women have cycle on the same day, now that's going to be such a difficult job, and they're in random 2 different cycles, and matching them gets difficult. So now that I can freeze the eggs, I just don't have to be worried. Randomly the woman's uterus is ready, the clinicians just have to tell us, okay, you can all start the cycle, I thaw the oocytes, I do the ICSI, I do the transfer. Life has become so easy. So for all these people wanting to do reproductive tourism, the man comes at one point, the woman comes at another cycle, we freeze the eggs, we freeze the sperm, we freeze the embryos. Time is something that we can actually freeze at this point, and that's making the couples have the cycles at their convenience. So freezing and everything is what's helping us. So that's the data of Oasis. In the last 10 years, most of them are onco patients. We've had 160 men freezing their semen samples before starting their oncotherapies. We've had 21 women freezing their oocytes, again before starting some medical treatments. 11 patients freezing testicular tissue because they were azoospermia, and we did a TISA and we froze their testicular tissue. We're hoping they're going to come back and have an ICSI with those testicular samples which we've frozen. And of all of them, 6 patients have had IVF with us so far in the last 6 years. So I think we all need to take this message loud across. A lot of surgeons are really helping and supporting us, but I think we still need to go a long way. I think when a patient is, a young patient who hasn't finished their reproductive needs, is wanting to undergo some kind of medical therapy which can put the ovary or testis at risk, I think we need to be offering them fertility preservation in one or the other form. That's the norm of the day. So again, ASRM said that oocyte freezing is no longer experimental. It's a routine clinical application and a routine clinical procedure that can be done, and that's what we've been doing at Oasis, and that's our success rates that we've published. So with frozen oocytes, we have had a live birth of 47% and 55% implantation rates and a miscarriage of 14%, which is comparable to the outcomes of fresh oocytes. Doing a cycle with fresh oocytes or frozen oocytes is not making any difference. A survivability is close to 95%, and thanks to the entire team in the laboratory, which really is helping us practice the science the way it should be. So we did speak about IVM. So again, take the pride always to share with everyone that Dr. Durga has been the part of the team in McGill University, Canada, where the first publication of IVM live birth was published in the Journal of Nature, which is a really highly impact factor journal, and she's been a part of that team where she's had the first publication, and she's continuing the concept of IVM. In fact, we have been the only clinic in the states of Telangana and Andhra Pradesh who've been offering IVM for a very long time, and very few clinics in India actually do that. And right now we are collaborating with the University of Brussels, where we are further taking up research projects with in vitro maturation, because we believe that the next level of IVF is to minimize the side effects. Most women drop out treatments not because it's not successful, it's because the hormones really bring a lot of side effects. It's so painful, there are so many injections, and IVM is a wonderful answer because we're going to give very minimal gonadotropins or no gonadotropins. And look at the success in the last 10 years, we've managed to give a live birth of 30 to 35%, which is probably 10% lesser to it. And this collaboration with University of Brussels, we are hoping the success is going to further go up, but that's the next level of IVF where we want to go. So that was with the ovary and the oocytes, which are the latest advancements and what we have been doing at Oasis. Now coming to the sperm and the whole testicular thing, Dr. Raghuveer did take us through a couple of case scenarios, how surgically we've evolved, micro TCs and helping people with their own genetic child. 1990s donor sperm, I'm sure we all agreed on that, but 2021 donor sperm is the plan Z. That's the last thing that we're going to be offering to the couple, and there's so much more that's evolved. Now we all know with the woman, it's right from stimulating the lady to doing a lot of endoscopic surgeries. There's so much of advancements with the drugs, so much that happens with the female partner. What with the man, take the sperm, do the ICSI. That's been the concept for a long time, but things have changed. There's so many advancements, and we've been really proactive in ensuring all these advancements are brought, and that's where the AndroLife Clinic evolved, and thanks to Dr. Raghuveer and his team who really do a wonderful job getting all these advancements in place. So sperm DNA fragmentation, what is this? Before we going there, we all know that a basic semen analysis gives us a very limited predictive value. We can't look at the report and we can't predict in what time the couple can conceive or with what intervention the couple can conceive. It's only screening and telling us there's a problem and you got to do something. But there's not much that's done, and there has always been a need for a sperm functional assay or a test which can give us a deeper insight of a sperm's fertilizing ability, and that is where a lot of research has gone into sperm's DNA fragmentation. So if your sperm's DNA is fragmented, it can either bring about recurrent implantation failure or recurrent pregnancy loss, or the embryos are not being formed. So test it, and it can affect your embryo's development, RIF, RPL, or let's say the patient gets lucky, fragmented DNA but still conceives. The research of late says that there could be a potential risk of epigenetic problems in the future neonate that's being born. So it's just not about giving success. I think IVF, we also need to be sure that the safety of mother and child is also kept up, and that is where we're going. I think the preventive medicine is now slowly getting into fertility practice as well. It's not about doing something and getting a couple pregnant hook or crook. You've got to look at the safety of mother and child as well, and sperm DNA fragmentation is one of that. And how do you handle that? There are a lot of sperm preparation methods. We've heard that you do a simple wash or a double density method, but there's so much more which separates sperms with good DNA, and that's helping us get better outcome. So magnetic cell separation, microfluidics, two of the latest techniques in the field. We have done a lot of research on that. Recently at the European Congress, a pride moment for Oasis, our paper was selected for oral presentation. We've done a randomized control trial to see which would be the best intervention. So there's a lot of thought that goes behind, a lot of individualization that goes behind. It's just not picking the egg and sperm and doing ICSI. There's a science behind it to ensure that we're giving the right success. So that's the data again published in Fertility Sterility in the year 2020. So what we ideally looked is 10 years data of Oasis, where we have done testicular sperm aspiration for men with raised sperm DNA fragmentation. So one of the interventions that's been tried in the world but still not convincing that would it really improve success is taking the testicular sperm. We all know azoospermia do a testicular sperm aspiration and then you do ICSI, but there's a newer indication. What we do is these men have sperm in the ejaculate, but that's fragmented. So it's getting fragmented while it's having its journey through the epididymis or the vas and seminal vesicle. So we want to go to the testis and directly take the sperm. It's less fragmented, it's got a good DNA quality. But we are picking sperm from testis which is not completely mature. Sperm has not finished its process of spermiogenesis at the testicular level. We're taking such sperms and we're doing ICSI. Is that a safe thing? For a very long time we have questioned and we have believed that testicular sperm might not give the best outcome, but that's our data published in Fertility Sterility, that even with testicular sperm we've given a live birth of 36%, which was statistically not significant with the control group where ejaculate sperm was used. So that's the newer thing that we're looking at in ensuring that we give the best pregnancy outcomes. So this was another data that we published in Fertility Sterility, where we compared testicular sperm outcome and the ejaculate sperm, 10 years data, where we just didn't look at our pregnancy rates, we also looked at the perinatal and neonatal outcomes. these women who had conceived with testicular sperm did not have an increased incidence of GDM, PIH or IUGR. There wasn't a higher incidence of low birth weight. There's a particular concept where we say if you're taking sperm of a severe male factor male and doing ICSI, the sperm's DNA is responsible for the placental issue. Epigenetically, it's influencing the placental formation, and such women are more prone for placental diseases. That's where there's been a concept that such women probably have a high incidence of PIH or IUGR, but our data has been reassuring. There's been no statistical difference with ejaculated sperm or testicular sperm. And we then looked at the congenital anomalies. This was a long study where a 5-year follow-up was also done. And we only saw one baby with Angelman syndrome with testicular sperm, and one of the child had rhabdomyoma. Both had no relation to the sperm, where it could have happened randomly to anyone. And in a control group also, I think one of the baby had hydrocephalus, one had ARDS, because all of premature delivery that had happened, and that's a complication we all know is a common thing to happen in an IVF conception. But the data was reassuring, and it got published in Fertility Sterility again. So this was the paper which actually put across the statistics of abnormalities. A common question that most couples ask us, is my baby going to be abnormal? Is it going to be safe? And that's a wonderful numbers that you all could take and discuss and put it across to your patients. So there's a 9% chance of birth defects in IVF conception, whereas in a natural conceived pregnancy it's 6.6%. 6.6 versus 9, that's not an alarming trend at all. 0.3% of IVF babies had malformations of eyes, where it was only 0.2% with natural conception. 5% of IVF babies had heart defects, where 3% of naturally conceived children had that. 1.5% of IVF babies had genitourinary defects, where it was 1% in the naturally conceived. So that whole numbers are trying to tell us that so far so good. We still are not saying that IVF is safe. And especially ICSI method, what we're doing, we're going and putting the sperm into the cytoplasm of the egg. You're touching a lot of cytoplasmal organelles. We don't know what kind of problems are going to come in the future, but so far that's why we've gone ahead and published the Indian data, which sounds and seems to be quite reassuring. So again, there was a publication of the Chinese data in Nature of their 10 years experience, and then we published this at ASRM, which is the American Society. The outcomes of testicular sperm looked all okay. So what we want to make it loud and clear in front of you all is, yes, male factor is increasing. So donor sperm is not the answer. There are a lot of interventions, a lot of things that can be done, and the couple can conceive with their own DNA. Another thing, I think with so much of freezing we're talking about, first of all, testicular sperm is something that we're not convinced is safe, in that we're now freezing the sample and then doing it. Would it really give the best outcomes? Again, the data says it's all safe. But one thing, if you're planning a testicular biopsy for an azoospermic individual, if you're not freezing the sample after the biopsy, if you see sperms, I don't think that's the right thing to do. Just doing a trial biopsy, sending for histopathology, getting a report of normal spermatogenesis, then referring to an IVF center where you're going to repeat the testicular biopsy. In the present scenario, not taken, because your freezing methods are so improved. At Oasis, we do all trial biopsies, we freeze them, and the patient just has multiple cycles after that. So repeated testicular biopsies could be avoided, and that's actually bringing the man's stress further down. Men are not that easy to handle in fertility clinics. Women are far more easy. I've had men collapsing in my OPDs, sitting crying, not accepting, that whole male ego thing, saying that, you are the reason for infertility is not welcome at all. So I think doing such interventions really help us go a long way there. So that, and as I said, we do a lot of microfluidics, newer ways of processing sperm. What a magnetic cell sorting microfluidics does is, it helps the sperms with good quality. And that's, your raw material, your egg and sperm is of good quality, you're going to get good embryos, the implantations are better, the outcomes are better. So we've tried our best to get all of this on board. And that's our success, which again was all published in Human Reproduction and Fertility Sterility. So that was with egg and sperm. Now coming to the embryo, that's my field. I've put in so much of years of my time there, thanks to Oasis, which gives us a wonderful platform. As embryologists, we all love working at Oasis for one reason, that they give us a wonderful platform which is full of latest science, and it's full of technology out there. So, success is just not about you getting the right egg and sperm. You could give me the best egg and sperm, and if I don't do a good job in the laboratory, I can totally screw up the whole thing. All your efforts of stimulating the lady and doing a lot of other things, a simple thing, if my lab is not good, I will not give you the best embryos, that will not give you the best success. So a lab really takes you a long way in terms of success, and I think our labs are well designed. We put in a lot of effort. The entire focus is on the IVF laboratory when we come up with new centers. So our air quality is the best, we get the best gadgets, our culture media is all well validated, and quality control. I've even had certain embryologists come up to me and say, what, I can't work with Oasis anymore because I can't really do so much of quality control and paperwork. I think that's our DNA. If you want to come and work at Oasis, 60% of the time, even in the clinical side, we do a lot of documentation. Without documentation, without auditing, without knowing what we're doing, I don't think we progress further. I think that is one of the core values which has helped us offer and do the best in the market so far. So our embryology lab is well designed and state of art. Picking the best embryo. There are times with all that technology I've got, of the 10 eggs, at least 5 become blastocysts. That's been the conversion at Oasis. And there comes the confusion what to put back. And we have actually evolved with a lot of ways of picking up the best embryo, and PGT is one such way of optimizing embryo selection. And all of this is actually implemented at Oasis. The latest being omics, which is metabolomics. So we have actually tied up with one of the universities to do the metabolomic study. So what we are right now doing is, this is non-invasive. The spent culture media is taken and we assess for a lot of metabolites, and that tells us which embryo scores the best. So we're trying to put in a lot of science there to ensure we improve the success. Finally, it's all about, I think now artificial intelligence is getting into the medical scenario as well. And be it cardiology or neurology, we are getting these machine-based learning softwares which are telling us what is the prognosis of the patient. And in IVF also this is happening, and we've collaborated with an Australian university, Monash, and we've started doing our deep learning thing. We've given our data of 10 years, and we are coming up with an algorithm which would tell us, in an IVF cycle, you put the patient details and the embryo details, and the software tells us what is the probability of pregnancy or an embryo being implanted. Well, that's, you're going to hear soon from us. Once we are out, we will have a press launch of that, but that's another way where we are wanting to improve on success of the patients. So fresh or frozen embryo, Dr. Sreevani was talking all about this. I think it's not really making a huge difference, but we do a lot of frozen embryo transfers because it's comfortable for the patient, for us in terms of taking care of the logistics of the cycle. And the biggest thing, OHSS. I think when it's stimulation, we all are worried about OHSS. A simple thing, freeze the embryos, don't put back the embryos. That's itself is one of the management strategies to get over the OHSS, and now we're talking about OHSS-free clinics. And I think vitrification of freezing the embryos and putting back another cycle has been one of the major steps in conquering the risk of OHSS, and we've had our fantastic live birth rates with frozen embryo transfer cycles. And I think that is the curve on the last 5-6 years, where with frozen embryo transfers, we've managed to give a live birth close to 60%. To put back a day 3 cleavage stage embryo or a blastocyst stage embryo, there's no doubt, I think even the Cochrane review says that with a blastocyst transfer, you're going to get the best live birth rates. And at Oasis, we've maintained a 55 to 60% live birth rates. But putting back a cleavage stage embryo is giving you a very limited success. And at Oasis, we barely do any day 3 transfers because our labs are well quality maintained, and we know the outcomes and our conversions are the best. So we counsel the patients that doesn't matter if you have a cancellation. But if an embryo is not viable, putting it back on day 2, day 3, putting 4, 5, 6 of them, if they don't have the viability, it's not going to make any difference. So a blastocyst transfer is the best at this point in time. Whether to put back 1 or 2 embryos, I think putting back 1 embryo to 2, look at the pregnancy or live birth rates, 35, 46. I don't think that's a huge difference. But look at the multiple pregnancy rates, 3% to 23%. I'm sure a lot of obstetricians out here would hate IVF specialists because we send them multiple pregnancies and they're sitting there whole night taking care of these high risk pregnancies. And for the couple per se, look at the financial and the mental burden we're putting on them if it's a preterm delivery. So very clear, it's put across, twin pregnancy in IVF is a failure. It is a failure of the clinical team and the lab team because we have not been successful in picking up the right embryo. So a single embryo will not really compromise your live birth rates to like single digits. There's just a 10%, but nothing is more important than safety of mother and child. That is undoubtedly, that's something that we have to keep in our mind when we're doing IVF as well. So finally, with recurrent implantation failure, what are the advances that we did? Because failure is a part of IVF game. You know, I'm not standing here and saying, you know, Oasis got a 100% success rate. Absolutely no. We are with the world standards and it's the max of 50, 60%. So what happens when a couple has a failed cycle? Do you say donor? The answer is absolutely no. In fact, the donor cycle incidence at Oasis has been less than 5% with all these advancements that we've had in the laboratory. So for recurrent implantation failures published in Human Reproduction way back, we said that, you know, these women didn't have a pregnancy before. They had a failed implantation. We did PGTA, we put back normal embryos, and we did manage to give them a live birth of 58%. Otherwise, these people wouldn't have had a pregnancy there. So PGTA is really helping the women to get over. There's been a recent STAR trial, if you people are aware of that, which said that, you know, overall of the last 10 years that PGT has been done, it didn't improve the live birth rates. As in a woman who's getting 2 or 3 cycles, cumulative live birth, versus doing 1 cycle of just PGTA screened embryo, they said the live birth rates was fine. It was spending so much of money because PGTA is costing the patient an added 1.5 to 2 lakhs. It is an expensive intervention to do. Now, on the whole, am I really doing justice? And more so in an Indian scenario, I got to be thinking of patient's pocket. Just because the technology is available, I just can't throw 10 different interventions and make the cycle expensive, wherein I've not really justified it. So what the STAR trial or any meta-analysis at this point says, PGTA is reducing the time to pregnancy. You know, younger generation have got no time. You know, they are happily not wanting to come to the clinics till 37, but when they come at 37, they expect the next cycle they're going to miss. So that time to pregnancy, how do I really take care? I think PGT is a wonderful tool to do that. So we just need to think out of the box. It's all about individualization and personalizing the treatments. That is what at this present scenario that we're looking at. You know, laser assisted hatching, we do laser assisted hatching on the embryos because in vitro culturing can harden up your zona. We've done that, but again, our experience, routinely doing it for everybody doesn't make a much of difference. If you've really seen a very thick zona pellucida, you could do that, and that's been our experience, so we don't really advocate all of that. So quickly bit about the PGTA, I think RF couples, it did make a difference. In RPL, it did make a difference. I'm just rushing through because we are short of time, and Dr. Sreevani took us elaborately with how PGTA did make a difference in RIF and RPL patients. This is our unpublished data which is going for publication this year. We looked at the role of PGT in advanced middle age women. You know, with career becoming such a big thing for all of us out here, wonderful thing, I think I need to have an answer and solution. At the age of 40, a lady comes and says, I want to have a pregnancy. Donor is not the answer. Donor can't be the answer. And we know at 40, the aneuploidy has gone up, the reserves come down. With lifestyle being so bad for all of us, they're most of the time diabetic, hypertensive, etc., or BMI is on a higher side, and that just puts, as fertility practitioners, a lot of challenges to us. So doing PGTA has helped these women shorten their time to pregnancy. You know, of the 4 or 5 blastocysts that we get, we can see which ones are euploid, put that back, her pregnancy is going up by at least 30%. Without doing PGTA, a normal IVF cycle for a woman who's 40, 42 will only give you a 10% success rate. But with PGTA, this is our own Oasis data, we had a live birth of 58%. The control group was the woman with advanced maternal age where no PGTA was done, and they only had a live birth of 38%. 38 to 58%, that's making a huge difference. So PGTA will also help women with advanced maternal age. So I think the recipe of success, you know, like what's the best recipe of your mother's biryani on a Sunday or chicken dish done on Sunday, I think we all can go gaga about it. So what's the recipe of success of my laboratory is all of the science and technology. It's a lot of hard work, it's a teamwork. I alone haven't accomplished all of this. It's a huge team which is constantly working. We keep telling them all of these are babies inside. If you are to be careful with your child when you're picking up, that's what you're going to be doing. So a lot of quality control goes in, and it's just not the success. I think we also work a lot on patient safety, and that is where the Oasis IT team has been doing a lot of innovative things and offers the best treatments. And with that as the electronic witnessing system which we launched, this is the first clinic in India to launch a electron witnessing system where we are trying to assure the patient, give them that comfort that there was no mix-up that has happened. You know, genuinely your DNA has been retained here, and they get a printout of all of this. Every step is actually monitored, and they know that, you know, there was no mishaps of this. And ARTIS, which is our electron medical record system, which has really helped us bring in a lot of efficiency in patient management. So with that, I'll end, but that's been a collective thing in the last 10 years where we have done a lot of work to ensure that we get the best technology to the people in our own place. You know, I hail from Hyderabad. I studied in Australia. I had my PR that I got in Australia way back 10 years back. I came back like anybody else. I wanted to go back to Australia. For a simple reason, I thought whatever I had learned in Australia, I will not get to practice here in India. Hyderabad is not really up to the mark. Probably the technology is not advanced. But I was wrong. In 6 months, Dr. Durga gave me a platform at Oasis which helped me live my dream. And it never gave me an opportunity to go back to Australia. Otherwise, I would have been an Australian citizen today, not talking to you all. But there was a team which believed and gave me that platform, and the rest has been history. So whatever's been there, it's there. So I think as Indians, we are nowhere less. I think we are doing the state of art, the best thing. It's just that we don't get out and talk about it. We don't want to publish. So with all the younger people who are sitting there in this, I think let's take the encouragement from a lot of seniors who are sitting here. They'll guide us, but we need to publish. Unless you tell the world the wonderful work that you have done, nobody is going to hear you out. It doesn't matter, I've done 100 cycles or 10 sections in a day. I'm sure all of us are doing a wonderful job doing that, but unless you publish and you tell the world, people are always going to look at the white world and not at us. But we're doing a fantastic job, and that's the proof that we're showing. Thank you everyone for that patient listening. Any questions, we'd be more than happy. Thank you.
Much, Dr. Well, I think we are now moving towards the fag end of the session, and we at Oasis Fertility, we strongly believe that it's, there's always a payback time, and then this is the time now. We would like to acknowledge some of the doctors who have not only worked relentlessly during the pandemic, but also throughout their journey. To begin with, first of all, it's my honor to call upon Dr. Iqbal Jahan Madam over to the dais. So we have a certain felicitation to some of the leading doctors of the city. So I would request Dr. Iqbal Jahan Madam, who is currently working as HOD at Princess Durushavar Hospital, and she has earlier worked as Professor Osmania Medical College between 1983 to 1996, and she has served as a Professor of Deccan Medical College from 96 to 2003, and worked as Professor at Kurnool Medical College and Tirupati Medical College. So to do the honors, also I would request Dr. Lakshmi Ji Madam. Dr. Lakshmi Ji Madam, I would request you to come forward, and as a token request her to present a shawl to Madam, please. I would request Dr. Garuda Lakshmi, Madam. Yeah. To hand over the memento, please. Yeah. Moment. And we would also request Dr. Shushila, Madam, to kindly come forward and hand over a gift. If you could just stay back, ma'am, for a picture. Thank you so much, ma'am. Thank you so much. Yeah. Our next dignitary, I would call upon Dr. Balamba, Madam, to come on to the dais. Oasis team, can you kindly escort Balamba, Madam, please? Yeah. Dr. Balamba, Madam, is currently working as a senior consultant at Shalini Hospital, and her experience goes a long way. She served as HOD and Professor, Department of OBG and Gynec at Usmania Medical College. She was also an additional director at Medical Education, and she worked as Professor Emeritus OBG and Gynec at NTR Health University, and she's a former President FPAI Hyderabad chapter as well as Chairperson governing body. Prajwala Anti-Trafficking Agency, it's an NGO primarily, and she has fellowships and memberships, and she's also advisor committee to Chief Minister of Andhra Pradesh as well as member advisor committee to Government of Telangana. A lot of laurels for her. Now I would request Dr. Swapna Kumari, Madam, to kindly come forward and honor her with a shawl. Also, I would request Dr. Pamni, Madam, to hand over a bouquet. Dr. Pamni, Madam, can you come forward, please? I request Dr. Pamni, ma'am, to hand over the bouquet. Sreevani, ma'am, if you could kindly hand over the memento to Balamba, Madam. And I request Dr. Anuradha, Madam, also to come forward and hand over a gift. Dr. Anuradha. Yeah. Thank you so much, ma'am. Thank you so much. Next, I would like to call upon Dr. Sujata, Dr. M. Sujata, ma'am, to come on to the dais. She's our next dignitary whom we are acknowledging, and for this, I would request Dr. Venkat Lakshmi, Madam, to come forward to honor her with a shawl. Also, I would request Dr. Anita Reddy, Madam, to come forward and hand over a bouquet to her. I would request Dr. Krishna Chaitanya, if he's around, yes, to kindly hand over a memento to Dr. Sujata. And I would request Dr. Pallavi, Madam, also to come forward. Dr. Pallavi. Dr. Pallavi, ma'am. And Dr. Pallavi, ma'am, if you could hand over a gift to her. Thank you so much, ma'am. Thanks. I would now request Dr. Anita M. Madam to come forward. Dr. Anita has been working as senior consultant in Pratima Hospital, and also she's worked as a professor HOD in Narayana Medical College, Nellore, and worked as a professor and HOD at Tumbe Hospital, as well as SV Medical College, Tirupati, and she served as a superintendent at GMH Sultan Bazar, and she also worked as a professor in Medicity Medical College. Talking about her awards and honors, she was awarded as Vidyashri, awarded by Shilpakala Vedika, as well as the Best Gynecologist and Obstetrician Award for 2017 in Twin Cities. I would request Dr. Bharti Devi to come forward for honoring with a shawl. Dr. Bharti Devi. And I request Dr. Lakshmi to come and hand over a bouquet to her. Sreevani ma'am, if you could give that memento. And I would request Dr. Sadhvi to come forward and hand over a gift to her. Thank you so much, ma'am. Calling upon Dr. Kalyani Devi, ma'am, to kindly come onto the dais. It's been our honor to have you all here, ma'am. Talking about Dr. Kalyani Devi, she is currently rendering her services at Vaishnavi Clinic at Champapet, and she has got 3 decades of experience in teaching, and she retired as a professor from Government Medical College Hospital, at Nayapur, and she has been awarded as the best professor by GMH. Now I would request Dr. Girija, Dr. Girija madam to come forward, please, and honor her with a shawl. And I would also request upon Dr. Mirinalini ma'am to come and hand over a bouquet to her. And I would request Dr. Raghuveer to kindly come forward, hand over a memento to her. I would request Dr. Saroja ma'am to come forward, please, and hand over the gift to Dr. Kalyani ma'am. Thank you so much everyone. It has been all under, okay. There is a request from the press here that all the dignitaries, if you could come on to the dais please again, all the 5 dignitaries. Yeah. The press would like to take a photograph of yours, ma'am. Sreevani ma'am, if you could join kindly. Chairs yalla. Nilabadtar, no problem. Nilabadtam, no problem. I think. It's okay. As we conclude, I would like to close this session with a big thank you to all the doctors. In spite of their busy Sunday, I think they have shown up here. Thank you so much, everybody. I would thank you, Dr. Sreevani ma'am, Dr. Krishna, as well as Dr. Raghuveer, who have presented us with a wonderful session. And in fact, sincere thanks to all the people who have organized this session. I would now request all of the doctors to join us for lunch. Thank you so much.